Now, my pleasure to introduce Dr. Carlos Del Rio, who is a distinguished professor of medicine in the Division of Infectious Diseases at Emory School of Medicine and the Executive Associate Dean for Emory at Grady. He is also Professor of Global Health in the Department of Global Health and Professor of Epidemiology at the Rollins School of Public Health. He is also co-director of the Emory Center for AIDS Research, CFAR, and co-PI of the Emory CDC HIV Clinical Trials Unit and the Emory Vaccine and Treatment Evaluation Unit. Dr. Del Rio is a native of Mexico, where he attended medical school at Universidad La Salle, graduating in 1983. He did his internal medicine and infectious diseases residencies at Emory University. In 1989, he returned to Mexico, where he was the executive director of the National AIDS Council of Mexico from 1992 through 1996. In November of 1996, he returned to Emory, where he has been involved in patient care, teaching, and research. Dr. Del Rio was chief of the Emory Medical Service at Grady Memorial Hospital from 2001 to 2009 and chair of the Department of Global Health from 2009 to 2019. Dr. Del Rio's research focuses on the early diagnosis, access to care, engagement in care, compliance with antiretrovirals, and prevention of HIV infection. He has worked for over a decade with hard-to-reach populations, including substance users, to improve outcomes of those infected with HIV and to prevent infection with those at risk. He's also interested in the translation of research findings into practice and policy. His international work includes collaborations in the country of Georgia, Ethiopia, Vietnam, Mexico, Kenya, and Thailand. He has also worked on emerging infections such as pandemic influenza and was a member of the WHO Influenza A H1N1 Clinical Advisory Group and of the CDC Influenza A H1N1 Task Force during the 2009 pandemic. Recently, you have seen Dr. Del Rio all over the different media outlets talking about COVID-19. Among his many honors are the James H. Nakano Citation received in 2001 and awarded by the CDC for an outstanding scientific paper published in 2000, Emory University Marion V. Creekmore Achievement Award for Internationalization. He was selected by Atlanta Magazine as one of the 55 most influential foreign-born Atlantans in 2007. In 2013, Dr. Del Rio was elected to the National Academy of Medicine, and in 2020 was elected as the Foreign Secretary of the National Academy of Medicine. He is also the chair of the PEPFAR Scientific Advisory Board. He is the chief section editor for HIV/AIDS for the New England Journal of Medicine, Journal Watch Infectious Diseases, associate editor for Clinical Infectious Diseases, and member of the editorial board of Journal of AIDS and Global Public Health. Dr. Del Rio has co-authored 30 book chapters and over 350 scientific papers. Dr. Del Rio, over to you.
Well, thank you very much, and thank you for the invitation. I am delighted to be with you and to share a presentation about COVID-19 and what the current status is. Can you see my slides?
Yes, we can.
Okay, so we will try to cover certain aspects and try to see if we can talk about, the past, the present, and where we are in the future, and where are things going. The COVID comes from the word coronavirus, and coronaviruses are enveloped RNA viruses that are named for this corona they have in their service, this characteristic in their service that gives them this very typical appearance on electron microscopy. And that protein in the surface is called the spike glycoprotein, or S, and that's actually where a lot of the vaccines are directed to. Coronaviruses are frequent. They are cause about 10 to 30% of common colds. They tend to replicate better at lower temperatures, and that's why they're predilection for the upper respiratory tract. And they tend to survive well in the GI tract. And their transmission and control, it has proven to be difficult multiple times. This is a new coronavirus that was discovered on recently. And you can see here in the phylogenetic tree that this coronavirus sits very close. This novel coronavirus is very close to the so-called SARS coronavirus, the ones that cause SARS. But there's other coronavirus diseases like MERS that sit way out here. So it relates more to SARS than to the other coronaviruses. It is important, though, that the SARS and the current SARS-CoV-2 coronavirus use the angiotensin converted enzyme 2 receptor, and that's how they get access to cells. This pneumonia, this syndrome, was first described in the city of Wuhan in central China. And Wuhan, for many people, is in China. They describe it, I had no idea about Wuhan in China, but people there Chinese describe it to me like the Chicago of China. It's in the center of the country. It's a major hub for industry, for business, for commerce. On December 31st, the WHO China office was informed of this case of pneumonia. And by January 7th, the Chinese authorities identified this novel coronavirus as a probable cause, and the virus was named SARS-CoV-2. And since then, we have over 32 million confirmed cases globally and close to 1 million deaths globally. Now, what is the relationship with bats? Well, bats make roughly 20% of all species of animals and mammals in the earth. They have ability to fly and transmit viruses across, and they have evolved with an immune system that allows them to tolerate infections such as this one. There are multiple coronaviruses, and many of them live in China, and that is why China is a hotspot for bat-borne coronaviruses to emerge. And they tend to have an intermediate animal between the bats and the humans. And in the case of the SARS-CoV-2, it's likely an animal called the pangolin. Again, a very strange looking animal that is one of the most trafficked species in the world. This is a picture I took of the Hopkins website back on February 1st, when there were only 17,000 cases globally, and most of them were in China. And the great majority of the 17,000 cases, 16,000 were in mainland China, and the great majority were in Hubei province, there in the center. This is the same map, the same picture I took this morning, in which there are 32 million cases globally. So that is what a pandemic is. It went very rapidly from one point to really being global and being something that has rapidly impacted the world, the way we do things and the way we act. So as I said, globally, 32 million cases, close to 1 million deaths. In the US alone, we have over 7 million cases, and we've passed 200,000 deaths. There are 3 states with over 600,000 cases, and Georgia is number 5 with 300,000 cases. India is number 2 in the world with over 5.6 million cases, and Brazil number 3 with 4.5 million. Russia now has 1 million cases, and Colombia, Peru, Mexico, and Spain have over 700,000 cases. So the reality is, if you think about the 32 million cases, even though there's disease everywhere, some of the countries are really concentrating a lot of the cases. So this is what it looks globally. You can see India there on the lead and the US right behind it in number of new confirmed cases. But here you can see the 7-day rolling average, and you can really see how rapidly this has exploded in India. And I think that's actually very concerning to many of us. The mortality has also changed quite dramatically. You can see that back in April, a lot of the deaths were in the European Union, there in blue. But now a lot of the deaths are in Latin America, 38% of the global deaths. In the US, 13% of the global deaths. and now in India as well. The second wave in India, in Europe, is particularly concerning, both in Spain and in France, a rapid increase in cases. And when we look at this, one of the things that is striking is that if you look at hospital admissions and deaths, Spain, Madrid, and New York are different in the sense that admissions are going up in Madrid and deaths are going up in Madrid. And the main difference between Madrid and New York is that Madrid opened restaurants and bars early. They did so on June 8th. And New York is still not allowing indoor dining and doesn't plan to open indoor dining until the end of this month, a couple of days from now, with 25% seating capacity. So you can see clearly a big difference there between these two places, and talks about the importance of closed environments like bars, like restaurants, where transmission can occur. This is where we are in the US. Right now, we're experiencing an increase in cases. We have seen in the past week an average of 41,000 cases per day, which is a 7% increase from the previous 2 days. And this is what the country looks like. You can see the Dakotas and sort of the middle of the country having significant outbreaks right now, and the rest of the country, a great majority of the country, including here in the Southeast, being orange, in other words, being right underneath red. But besides the toll of deaths from coronavirus, we also have the deaths that we call from excess mortality. And this excess deaths not only include the coronavirus deaths, but include deaths from other diseases like heart disease, like lung disease, that have occurred, like cancer, because people have been unable to receive care for their usual diseases because of the pandemic. This is a website I'd like to go to because it tries to summarize on a regular basis not only health indicators like cases and deaths, but also economic indicators, standard of living indicators, and government indicators. And it's a good place to go to find out things like, what's happening to air travel, to the personal income, to food insecurity, et cetera. Here in Georgia, we're about 300,000 cases and about 6,800 deaths. So how is this disease transmitted? Well, it's transmitted mainly through respiratory droplets that land on surfaces and person to person. One of the things that we worry the most is transmitted from people who are asymptomatic or before they develop symptoms, and that's an important part of the transmission. In this cartoon, you can say there's been a lot of controversy between droplet and airborne. And this cartoon, what it tries to say is droplets and airborne are part of a continuum in which depending on the size of the respiratory molecules, some are big and called droplets, some are small and called small nuclei. And this virus tends to transmit more through droplets than through small nuclei, through aerosols. It can cause aerosol transmission primarily in closed environment, in crowded environments, and where there's no good circulation. So what's the difference between isolation and quarantine? Isolation is when you take an ill person and you separate it from others. So somebody diagnosed with an infectious disease is put in isolation. Quarantine is separating those that are doing well, but who could have been exposed to a communicable disease. This disease is characterized by an incubation period of about 5 days. 80% of the cases are mild, and 30%, actually 20 to 30% can require more intensive care, including ICU care. What we've learned is that this disease can affect more than just a cold or respiratory disease. It can actually impact the brain, and you can see strokes, and you can see cardiovascular disease. You can see an inflammation of the heart called myocarditis. You can see renal disease. You can see GI disease. So in other words, it is a systemic illness, not just a cold. And there are certain risk factors for severe disease, including old age, having lung disease, having heart disease, having diabetes. A major risk factor is having obesity, a BMI over 30. And what we see is a disproportionate burden of COVID-19 in racial and ethnic minorities and among the poor. And you can see the mortality goes up with age. The older you are, the more likely you are to die from COVID. It usually starts going up right around 60 or so. But as I said, the problem with this disease is that we're detecting a few patients, and there are a lot of people yet undetected because they're asymptomatic. And if you don't test enough, you're not going to diagnose those individuals. So it's very, very important to continue testing in order to diagnose those that are asymptomatic. The racial inequalities and inequities in this disease have been starting. And you can see there that the attack rate of cases is much higher for Blacks and Latinos than it is for whites. And that also among Blacks and Latinos, the attack rate increases starting at age 20, really, as opposed to whites, where really the increase in the really high attack rate is over the age of 80. And this infographic from CDC tries to put this in one table, basically showing that for African Americans and for Hispanic and Native Americans, the cases are 2.8 times what it should be. Hospitalizations are 5 times higher, and mortality is 1 to 2 times higher than what it is for whites. So as far as therapeutics, there's been a lot of interest in looking at drugs and therapeutics. But today, what we have as effective therapies are drugs that act as antivirals, particularly remdesivir, and drugs that act as anti-inflammatories, particularly dexamethasone. We're also working in antibody therapy, and antibody therapies can be done with convalescent plasma or through monoclonal antibodies that are currently being studied. One of the things that is concerning is that for a lot of people, you know, they worry, they say the pandemic is a health risk in the US, but it's not a local risk. It doesn't impact me and doesn't impact my community. And this has been particularly interesting among young people. And for Generation Z adults, we have seen a very significant drop in their concern about the pandemic. And as a result of that, what we're seeing is, for example, here in Georgia, you can see that the 7-day rolling average shows that a significant increase in cases is among young people. It's not among the elderly, it's among young people. We and others are working very hard in trying to develop a coronavirus vaccine. It is a global imperative because the virus, really controlling this pandemic is going to require having a vaccine. But you're going to require to vaccinate a significant proportion of the population to get immunity. The development of vaccine has been nothing short of amazing. We went from discovering this virus, sequencing the virus in January, having the best vaccine enter a human in March, and starting phase 3 trials in July. And the number of vaccines being tested are multiple. You can see how many of them are now in phase 3 and how many have been studied. And here are some of the vaccines that are most active right now. Pfizer, Moderna, AstraZeneca, and Johnson & Johnson have vaccines. You can see in phase 3 how many participants they have and when do we expect to see results from these vaccines. It's probably sometime in November to December that we'll hear the first results. But understanding the immunity to coronaviruses is critically important. And we know that there is a certain degree of immunity that is mediated by B cells and certain mediated by T cells. And in fact, how long the infection will last is something we don't yet know. And I think it's something that all of us are very interested in because, well, you need to be revaccinated or re-exposure will act as vaccination is something we yet don't know. I think when we talk about this epidemic, this editorial from yesterday, I think is very relevant. You know, we have been thinking about this as an infectious disease. We want to cut the viral transmission. We want to control the spread of the pathogen. But the reality is that we've learned that this is an interaction between one infectious disease and a series of non-communicable diseases like obesity, diabetes, hypertension. And these conditions cluster in social groups impacted by inequity, which are deeply embedded in our societies. And therefore, what Dr. Richard Horton proposes is that we not call this a pandemic, but a syndemic. And the importance of considering a syndemic is that addressing this will require us to really address the social determinants of this disease, will require us to address education, employment, housing, food insecurity, the environment, in order to really combat this pandemic. It's not just an issue of having a vaccine. And with that, I'll end and happy to answer any questions. Are there any questions? I'm looking at the chat.
Hey, Dr. Del Rio, just a question. As we're working on a vaccine and as the vaccine is eventually released, how safe will the initial vaccine be?
Well, that's obviously a very good question. I think we as vaccine researchers care more about vaccine safety than efficacy initially. We all want to be sure the vaccine is safe. And I can tell you that the vaccine will be safe, but we will continue monitoring the safety of the vaccine throughout the course. In other words, you don't stop looking at safety. And, we know that safety is very important. The moment that there was a safety signal, for example, in the AstraZeneca vaccine, immediately the study was put on hold, right? Until you can investigate that something was going on. So I think that I'm not that concerned about safety. I'm more concerned about efficacy. How efficacious will this vaccine be? At best, I think it's going to be 40 to 50% efficacious. It's not going to be 100%. This is not going to be like the vaccine for measles or other diseases.
And when it's initially released, how widely do you think it will be distributed?
Well, I think there's a lot of effort there's a lot of commitment and efforts to make it widely available. But I think it's going to be very important that we realize that it needs to be widely available globally because, there's no point on just vaccinating Americans, but not vaccinating everybody else, right? There's too much communication across the world that you really need to think about how do we immunize everybody, right?
And in the news, and especially with the president saying some things about the numbers of COVID-19 cases, from your experience, from your observation, what is the real case of the numbers? Are the numbers going up, or the numbers going down, or is it just kind of fluctuating depending on where you are?
It really depends on where you are, but in general, I think right now we're seeing an increase in cases in the country, in some areas of the country. So it depends where you are, right? Like in the Midwest, we're seeing a rapid increase. Here in Georgia, we're not seeing that huge increase. In fact, here in Atlanta, we're seeing a decrease. And New York and the Northeast, we're seeing a stabilization, a significant decrease in number of cases. So it really depends where you are.
And just from your observation, or just from your just opinion, what will life look like once the vaccination is released? And do we eventually go back to this new normal, or things go back to the way things were?
Well, it's very hard to know, right? It's very hard to know. I think it's going to take a while to get back to the way we were, because it's going to take a while to vaccinate enough people. So I think we're going to continue wearing masks and doing many things like that for, I would say, at least another year. I really don't think we're going to be out of this until sometime in late 2021. I tell people that, we may be back to the normal we used to like by Thanksgiving of 2021.
I have a few questions in the chat, and one question is, are there significant concerns for achieving immunity with a vaccine during a time where the anti-vaxxers have increased?
Well, yeah, obviously there is concern, right? I think there's a significant concern. And as I tell people, vaccines don't save life. Vaccination saves lives, right? You got to get the vaccines to people. And if we don't vaccinate people, then you have a problem. I think that we're going to have to do a very significant public education campaign to get people to take this vaccine and understand how important it is.
Another question in the chat. I live on the Navajo reservation. Several sites on the Navajo land have been selected for phase 3 trials. Many of our population are very resistant to participate because they feel that white people in the government are using them as guinea pigs. Any suggestions as to how to start that conversation?
I would say actually the opposite is happening. In fact, we are worried that some of the vaccine studies are actually including too many whites and not enough African Americans, Hispanics, and Native Americans. So we really need to work with the population to tell them to understand that it's very important that actually, because they're heavily impacted, that we ensure that they also participate in the studies. If they don't participate in the studies, I think we will not have results about the efficacy. We will not know about the efficacy of vaccine in specific populations. So I try to tell people that it's very important for them to participate. And in fact, you don't want everybody in a study to be white, right?
Another question in chat. Have the technologies used in these vaccines, mRNA and adenovirus, have been used in other widely distributed vaccines?
No, that's actually a very good question. They really have not. They really have not. The vaccines have not. These are totally new technologies, and these new technologies are very futuristic technologies in vaccine deliveries. I think if they work, I mean, the reason we're able to make the vaccine this quickly is because of this technology. The question is, how long are they going to work? And if they do, it may dramatically change the field of vaccinology. But that's a really good question.
All right, there are no more questions in the chat. Thank you, Dr. Del Rio, for a wonderful presentation.
So and I will be sure you guys get the slides so you can distribute them.
All right, thank you.
Thank you. Take care.